Now we're going to move on to non-invasive positive pressure ventilation, which consists of CPAPs and BiPAPs. So when discussing CPAP, it stands for continuous positive airway pressure, meaning it delivers positive pressure and only positive pressure continuously. And by delivering a continuous positive pressure, this is going to keep the airway open. So a CPAP is usually used for patients suffering from OSA, which is obstructive sleep apnea. Now, individuals that suffer from OSA, the airway is occluded because the throat muscles as well as the tongue relax and block the airway. That's when a CPAP is very beneficial because it's going to maintain the airway. It's going to continuously provide that positive airway pressure, which is going to keep the airway open by means of continuous positive pressure. Now we move to BiPAP. And BiPAP, this stands for bi-level positive airway pressure. And with BiPAP, instead of one continuous pressure, it delivers two continuous preset pressures, one for inspiration and one for expiration. So this mode is very helpful when removing carbon dioxide because remember, we can deliver an expiration, it goes both ways. Hence the prefix bi, meaning two. So if there's a patient on a vent and we see a blood gas where there's a high carbon dioxide, we can pretty much increase the respiratory rate, furthermore decreasing carbon dioxide. And the reverse holds true as well. If we see a low CO2 and we see a pH that is alkalotic and we want to bring it back a little down, we can slow the rate. And by slowing the rate, this is going to increase carbon dioxide because we're not releasing it, okay? Now, we're going to talk about intubation, which consists of an endotracheal tube and tracheostomy, okay? So we're going to see a bunch of stats on both the endotracheal tube and the tracheostomy. Now, we're going to start with the endotracheal tube and the bullets that come with it. Now, when it comes to ET tubes, they can be inserted orally or nasally. But orally is the preferred route, being that nasal intubation is considered a blind intubation because you're just pushing the tube up. You're really not sure which way it's going. That's what makes the oral route a little better because it provides a clearer visual when advancing the tube. Now, the tube should be inserted just above the carina. The carina is the bottom portion of the trachea that separates the left and right bronchi, and we want it 2 to 3 centimeters above it. Now, why 2 to 3 centimeters, you may ask? Well, this is due to the fact that the right bronchus is wider than the left one, and we don't want to accidentally intubate the right bronchi over the left. This is going to provide unequal oxygenation to the patient. You're going to see while delivering breath or oxygen to the patient, you're going to see the right lung expand and the left one partial expand or not expand at all. That's going to make us know or confirm that placement is morely in the right bronchi. So 2 to 3 centimeters is going to prevent that. Now, the next important bullet is the balloon of the endotracheal tube, which is to be inflated to 20 to 25 millimeters of mercury, which is going to prevent aspiration. If the balloon is not inflated enough to occlude the whole trachea and there's a little space between the balloon, well, pretty much whatever they aspirated is going to go down past the balloon into the lungs. That's called aspiration pneumonia, which can lead to various complications such as septic shock, which is why endotracheal tubes makes a patient at increased risk for pneumonia. Now, if intubation is taking too long, the nurse is to monitor the patient's saturation level and stop the respiratory therapist or the medical doctor and manually ventilate the patient. Provide some form of oxygen due to the occlusion the intubation was causing. Now, when the ET tube is placed successfully, that we hope, we're going to verify the placement by means of an end-tidal CO2, which is a device that measures carbon dioxide. Now, how does it measure the carbon dioxide exactly? Now, this device turns blue when CO2 touches it. And we're going to know that the tube is in the trachea and not the esophagus when this happens. We're going to put the device at the end of the tube, and if it turns blue, we know that we're getting CO2. Blue means CO2. Now, we're also going to want to verify placement by an X-ray, and checking for the rising and fall of the chest is important to make sure the patient is ventilating and not suffocating. So as for the nurse, you're going to document the placement of the tube in centimeters at the patient's lip, and it should be between 21 to 23 centimeters. Now, when intubating patients, it's going to be important to administer an analgesic for the pain, a sedative to relax them, and a paralytic that they don't feel anything prior to the intubation, okay? This is going to prevent any unplanned extubation. The patient can wake up and feel very uncomfortable. Prophylactically giving these things prior to the intubation is going to prevent any unplanned extubation. Next, we're going to discuss tracheostomies, which is the last slide of this presentation. This is required if mechanical ventilation is needed for greater than 7 to 14 days, so 1 to 2 weeks. So by switching to a tracheostomy, this prevents laryngeal or upper airway damage that an endotracheal tube may have caused or may be causing. So to make note of, it is inserted within the second tracheal ring, which is in the image, and it is actually more comfortable than the endotracheal tube. Now, besides comfort, oral care is easier done and lip reading is easier to see when it comes to the tracheostomy over the endotracheal tube. Lastly, the complications that's associated with tracheostomies is that of tracheal stenosis, which is the stiffening of the trachea, and this is due to scar tissue from the tracheotomy cut. Also, another complication is that of a tracheoesophageal fistula, which is a passage that has formed connecting the trachea and the esophagus. It pretty much is a hole between the trachea and esophagus, and this can also happen with the endotracheal tube as well, because if we overinflate the cuff, which is over that 20 to 25, if we inflate it too much, it can pretty much expand and expand and expand till we get a fistula within the throat.